Hello again. So this is your last hour. We stopped, I believe, here under the last thing I mentioned was we will skip the surgical interventions for diabetes. Let's proceed with okay. The next few paragraphs here are interventions for the other microvascular complications of diabetes, which are neuropathy. So let's begin with peripheral neuropathy. This involves preventing injury. As you can see here, these are our goals, okay, for the patient, that they will avoid circumstances that will lead to injury, specifically to their feet. Okay. This is a Charcot's deformity. This is again a deformity that will result from severe uncontrolled diabetes. It's not very common. The important thing here is again avoiding injury to the feet, because once these patients start having wounds, they typically don't heal very well, and so they will get infections on these injuries, and that will eventually potentially lead to amputation. Or if they're lucky, that the amputation will be the least of the problems. They might die from sepsis, especially after they develop osteomyelitis. Okay. We will skip table 64-10. Okay, there's no need for us to look at these risk categories. Let's go straight to foot care. Chart 64-6 is your foot care instructions. They are self-explanatory, so please pay attention to the details. Specifically, for instance, here, inspect your feet daily, especially the area between the toes, because those areas contain moisture. They collect moisture rather. When you do wash your feet, make sure they are dry. You can, because when you have peripheral neuropathy, the legs get dry, the feet also get dry. You are to put lotion on your feet, except between the area between the toes. Okay, that's an exception. Change into cotton socks daily. Do not wear the same pair of shoes. This is, of course, due to moisture. We want the shoes to at least dry properly, dry thoroughly before we use them again. Um, so read all the way down here. I can choose any of these bullets on exam questions, okay, because these are practical questions for foot care. I mean, every nurse is expected to know how to teach your patients about how to properly care for their feet. Wound care, it's important that these patients, once they sustain injuries or wounds on their feet, that they have to be cared for properly. Pain management, because they do have pain in neuropathy, in peripheral neuropathy, and these neuropathic pains are managed with usually anticonvulsants like gabapentin. These are anti-seizure medications. They work very well for these types of pain. The opioids won't work very well for these, so we use either anti-seizure medications or antidepressants, specifically tricyclic antidepressants. Okay, this is for the eyes. The patients, of course, are to be educated on having their vision tested every year at least. Okay, and again, all these complications can be managed or avoided simply by controlling their blood sugar, better. Same thing for kidney disease. Okay, um, there are um, some preventive medications here, like for ACE inhibitors, for instance. These may be options for physicians to do. The um, This is the purpose. Okay, it says clearly here is recommended for patients with DM who have normal blood pressure and normal albumin excretion. Okay, and because hypertension does accelerate the progression of kidney disease. All right, so since hypoglycemia is here now, um, I did mention earlier during the first hour that among the three, namely DKA, HHS, and hypoglycemia, we will cover hypoglycemia for this semester. Reason is you will encounter these in clinical, so that way you know how to manage them, recognize and manage them as early as now. I mentioned either in the first or second hour that hypoglycemia is a life-threatening condition. So any life-threatening condition will trigger the sympathetic nervous system. That's why on table 6411, most of your symptoms here are related to specifically this part here, the neurogenic symptoms. These are from the fight or flight response. The patient will have increased heart rate, will have vasoconstriction, so that's why you have here the heart pounding, and of course that will make you nervous and shaky. And then of course the vasoconstriction will be manifested by sweaty, being the patient being diaphoretic, and feels cold as well. They'll break out into a cold sweat. Of course, the hypoglycemia will trigger the hunger symptom as well, so that's why of course you'll feel that as well. Okay, but I did mention also earlier about people who are on diabetics who are on beta blockers that may affect their ability to recognize these adrenergic symptoms. Okay. Other symptoms are the following. Okay, these are consistent with being low in energy. No, because remember the brain in A&P, it's said to consume 20%, 20 to 25% of your total blood glucose. Okay, so the brain consumes a lot of sugar. Here is the hypoglycemic unawareness again. We mentioned this earlier. Okay, so this is defined again when patients have no longer feel the warning symptoms of hypoglycemia, which can be dangerous. Here is a side-by-side comparison of hypo and hyperglycemia, table 64-12. Again, this is self-explanatory. In hyperglycemia, these manifestations will also be present in DKA and HHS, which I already mentioned will be discussed in your 5th semester. But for this upcoming exam 2, you will be tested on hypoglycemia. There are different levels which we will cover shortly. These bullets here are the common causes of hypoglycemia. Most of them are self-explanatory. Let me just discuss gastroparesis. Okay, now if you remember in under the insulin table earlier, so normally food stays in the stomach approximately 1 to 2 hours after a meal. Okay, so food sits in your stomach for 1 to 2 hours. All right, the purpose of this is to of course liquefy the food you just ate, so the stomach acids will be there and then turn them into liquid, all right, before they enter the duodenum. So this is of course your stomach, and this is your duodenum. Now of course when the food enters the duodenum, this is now liquid, and this is now absorbable. Okay, so now the glucose, the food, the carbohydrates, fats, and proteins that you ate is now converted into glucose. So this is now ready for absorption. So this is again the normal physiology. Food sits about 1 to 2 hours in the stomach. Now, if you remember your insulin, so let's just say rapid or even short-acting insulin. The peak, if you remember, is about between 1 to 3 hours, which is, so if the peak is 1 to 3 hours, this will make it perfect to peak around the time that sugar is now absorbed in the duodenum. So your sugar rises about the same time when your insulin peaks. Okay, I hope you're following this so far. Again, food sits in the stomach for about 1 to 2 hours, and then at which time, so let's say 2 hours later, it enters the duodenum, and then this is now absorbed into the bloodstream, causing your sugar to rise at about 1 to 2 hours later, which coincides with the peak action of your insulin. So therefore, if all of your GI function is normal, so you'll have normal blood glucose because your insulin timing is just right as to approximately the time when your sugar also rises after eating a meal. Now, however, if you have gastroparesis, which is delayed gastric emptying, so as a result, your stomach doesn't, the food sits longer than 1 to 2 hours in the stomach. So let's say even if this goes up to 3 to 4 hours now before it empties, the insulin still peaks around 1 to 3 hours. So when this thing peaks, the glucose might not be high yet, okay, because you have gastroparesis. So in gastroparesis, there is delayed gastric emptying, so therefore the rise in blood sugar will also be delayed, which will now be incongruent with your insulin peak time. Okay, so therefore as a result, the patient will therefore not have high glucose by the time the insulin peaks. So it will peak much later when you have gastroparesis. That's why this thing is one of the causes of hypoglycemia. Okay. Then we just discussed earlier the effects of exercise, and also if your insulin is still a drug, so therefore if you give insulin to a patient with kidney failure, since drug elimination is impaired, so insulin will hang around longer in the bloodstream, resulting in longer effects, or as you may prefer to refer to as toxic levels. So the patient will of course develop hypoglycemia. Management of hypoglycemia, this is management at home. So there are different levels of hypoglycemia. We have mild, which is typically less than 60, and this is your management. The rule is 15-15 rule, meaning we check the sugar every 15 minutes, and we give up to 15 grams of carbohydrate. Okay, this is for mild, which is again less than 60 but above 40. And these are your choices. Okay, you don't give all of these. Each one of these is equivalent to 15 grams. Now for moderate, in mild, the patient's symptoms might be these. Okay, this is for mild, and then for when you go moderate, these are now the patient's manifestations. Okay, and the sugar level is now less than 40, in which case of course you give more than just 15 grams of sugar. So now you give up to 30 grams of sugar. In severe, the patient at this point is no longer conscious, so it makes sense that the patient, of course, we can't give anything by mouth anymore. Okay, so now we have to give glucagon. So your choices are, this is in the home. Okay, the title of the chart is Management of Hypoglycemia at Home. So we can, of course, this is the family member now that will administer the glucagon, either IM or subcutaneously. The dose is 1 milligram. It usually comes in a kit. So the family members would be taught, or even the patient will also be taught how to give this. The reason is hypoglycemia is tolerated differently by people. So you may still see patients with severe hypoglycemia that are fully awake, okay, in which case they can still give themselves um, IM or sub-Q glucagon. One more thing, I did mention that hypoglycemia is tolerated differently by patients. So let's say your patient's sugar is in under mild hypoglycemia. So let's say it's 55. However, if the patient is, of course, not tolerating it well, for example, the patient already unconscious at the blood sugar of 55, then please don't force 8 ounces of milk down their throat. Okay, they'll of course aspirate. So in which case the patient is under mild, however the symptoms are already of severe, then of course you'll have to implement the interventions for severe. Okay, so just use common sense. If the patient's unconscious, then obviously they're not tolerating hypoglycemia very well. You can't give them anything by mouth. In the hospital, okay, also this is at home. Okay, whenever you give glucagon, the glucagon of course will turn glycogen into glucose in the liver. This is the opposite of insulin. It's still produced by your pancreas, as you may know already from A&P. This drug does induce vomiting, causes the patient to be nauseous. So your number one intervention, of course, after giving it is to institute aspiration precautions. So elevate the head of the bed or turn them to the side, okay, because it does trigger vomiting. In the hospital, we can give 50% dextrose IV. This comes in an ampule. You can go in the sim lab. I'll show you what 50% dextrose looks like. Here's something to remember. The effects of glucagon and dextrose are temporary, meaning these are not permanent fixes. The only permanent fix to hypoglycemia is, of course, you give the patient something to eat. So after the patient is now awake, after you give either glucagon or 50% dextrose, once the patient's fully awake, no longer nauseated, then give them either a small snack or a meal would be best. Okay, I hope that's clear enough. Prevention, of course, if you look back here on the causes of hypoglycemia, so you just manage these or do the opposite. Instead of giving the wrong insulin at the wrong time, then avoid that, then you will avoid your hypoglycemia. Here's alcohol, or follow guidelines for alcohol, for instance. Exercise, sorry. Follow proper guidelines of when to exercise. In any of these, the patient is supposed to check the sugar. Okay. And that's it. This is the end of your class. As I mentioned on the first hour, we will cover preventing DKA, management of DKA, same thing for HHS, as well as prevention. Here we'll cover sick day rules, which is chart 64-8, but again, this is all will be discussed and tested in your 5th semester. Okay, so we will go back to this part of chapter 64 in your 5th semester in NUR 205. Thank you.